Ask the Expert with Dr. Raj. April 17th. Again, we're happy to have you here. Life and Breath Foundation is happy to be able to share insights and awareness from various subject matter experts throughout the United States. So we've been at this for the last 4 years, really coming out of COVID. So, we're essentially very happy to do that. So just real basic background of the foundation and why we exist. Just really upfront, our primary goals are to offer the sarcoidosis community effective tools to track each person's journey, decipher medical issues, and maximize their quality of life. We also want to provide this in a nurturing environment for those affected by the sarcoidosis to be able to share their experiences. And quite frankly, you're not by yourself. You don't have to do it by yourself, no matter regionally where you live. We want to bring it to you. We want to plant that flag in the ground, hoist it as high as possible so that you can see us and we can be there as a resource and to be able to help you in your journey. This allows us to build that awareness necessary also within the medical community so that they can help combat the chronic disease. So it's going to be a balance between educating patients, caregivers, and naturally the medical community. My hope is Life and Breath Foundation can bridge that gap. Life and Breath Foundation is a volunteer-led organization, and all the money we receive through donations and sponsorships go directly to supporting patients with sarcoidosis. Some of the ways that we do that in terms of our services: monthly speaker series, events such as tonight. All replays are on YouTube. We've built a library to be able to familiarize you with the different topics that could be meaningful and help you through your journey. We also have sponsored and will sponsor a Life and Breath Scholar program, which is more towards the physician education component of our journey. We figure if we can create this educational background and understanding and awareness early in a physician's career, maybe when they're a resident or as they come out, we will have long-term ambassadors to be able to help our patients, especially if patients are suffering in multi-organ function and what have you. So also we have patient support groups and sarcoid experts that we introduce on a monthly basis. We do patient support through sponsorships and education. And then the last of which, and one that we're really excited about, is more recently we've created a Life and Breath planner. It's a digital tracker. It's also in a paper form that we're able to help you track your journey, track various things that are going on with your life so that we can make the exchange and experience when you do go see that specialist, you go see that doctor, it actually be more meaningful, and we can actually create more of an understanding and a relationship with your healthcare provider. Dr. Raj, just an incredible background. Again, I'll let everybody read through it and everything. More than 20 years of doing it between seeing patients and putting in the time, especially, what you're doing as an associate professor at the University of Southern California, being a director in the internal medicine residency program and associate director of the sleep medicine fellowship. Just a resilient career. You're currently an active clinical researcher and a teacher for more than 20 years. So we're happy to have you with us tonight and welcome.
Oh, thank you so much.
Awesome. One important disclaimer that we usually go through is we want to make sure everybody understands that this webinar is not meant to give any medical advice. There's no doctor-patient relationship that's being established by talking with Dr. Raj this evening. Our speaker does not know your medical background and therefore cannot give you any specific medical advice. We suggest for you to speak with your doctor before acting on any of the information that's shared this evening. Dr. Raj, make sense?
No, I love it. I love this disclaimer. I'm gonna make it a t-shirt.
Well, let's dig right on in.
Okay, you got it.
First question is it possible to resume cycling with cardiac sarcoidosis with ICD? No heart failure.
Yeah. Oh,
but new DX of CA with arrhythmias?
Oh my God. So I think this starts off with the very, I would say, spicy topic of cardiac sarcoid. So when we talk about cardiac sarcoid, number one, did we make the right diagnosis? And that is always going to be the first thing. Because when we talk about heart failure, remember that, heart failure can happen for people who have high blood pressure, who have type 2 diabetes, who tend to be overweight, who tend to have bad, health choices, unfortunately. But of course, if you carry a diagnosis of sarcoid, it definitely can affect the heart. Common things being common, it's a sarcoid lung combination. So when I say sarcoid heart, is it going to be sarcoid there? And it's hard to make the diagnosis because we don't go around biopsying the heart. That just sounds like a horrible idea based on what happens if an error happens in the biopsy. So of course, we're going to use imaging, whether it's going to be a PET scan, whether it's going to be an MRI. We use our clinical knowledge of the patient. We use blood work like inflammatory markers, and we have to make a consensus with the diagnosis. And because we can't always get tissue in the heart, it becomes to what is our probability? Are you someone who is at high probability of having this, a high risk patient? So we risk stratify the way it's going to be. And I really emphasize that's important because when we talk about cardiac sarcoid, well, when you're not doing well, the question becomes, well, is it the heart just doing heart things? You're going into heart failure because you have heart disease, or do you need to immunosuppress them? And that's the hardest question in the whole world. How do we know there's active inflammation in the heart? And that's not an easy decision to make. Now, I'm not skirting around this question. I know it said ICD and can I do things? So my first thing is, when we're talking about an ICD, I don't feel that you need to just jump in right away and say, put an intracardiac defibrillator in me as the first thing. Of course, that depends. And of course, I do want this patient to be teamed up with a cardiologist. And when you say arrhythmias, well, are they things from the atria? Is it atrial fibrillation? Is it things that we call PVC, premature ventricular contractions? Or is it something in ventricle like VTAC? What happened when you got these arrhythmias? And a decision needs to be made that, are we going to put this intracardiac defibrillator in you because of these arrhythmias? Or maybe it's because of the fact that your heart is not pumping well, or we call the ejection fraction could be low, where you need to put one in anyways for a primary prevention. So if you have one in already, this could be the biggest pearl in the whole world, is that the minute you have a pacemaker or an ICD, you can't do anything with raising your arms like this for 6 weeks. Why? Is because of the fact that if you start doing things like this or lifting weights or even driving, you may pull one of these leads off. So that's not even a sarcoid thing. That's a cardiology thing. That's a who placed your pacemaker. Here's your pamphlet. Make sure you don't do anything that raises your hands. So if you're saying cycling, I wanted to emphasize, sure. And how long does it take after you get an ICD placed? Nowadays, these cardiologists are pretty good and people could start doing lower extremity exercises right away. But once again, you can't be lifting your arms up or putting it like this. So I really feel the take-home message is, how do we know it's the sarcoid is involving the heart? My first thing isn't always going to be, you have cardiac sarcoid, put an ICD in. You really need to get evaluated. What arrhythmias, what symptoms, how much do we feel it's going to be the heart? Should we try immunosuppression medications first? But of course, there are big red flags, everyone. If you had an arrhythmia like VTAC and you fainted, we use the medical word syncope. If you had cardiac arrest or any of these things, of course, we're going to be more aggressive. So that's a really super spicy question with so many ways to go. So my advice to you is nothing in the upper extremities for 6 weeks. Cycling, yes, you can do it. Just be careful.
So sorry to start you off with a real spicy question, but
yeah, my mouth is still hot from that one. Oh my God.
I tell you, might as well jump right in. But this is related to some of your response, and it may be the 6 months, I'm not sure. But the next question, I think it's related, is...
Oh, did I say 6 months? Oh my God. You know what? I'm in the months category. It's 6 weeks, everyone. It's 6 weeks. Yeah,
Okay.
I said 6 months, and I gave you a heart attack. then that's my fault. Please don't get a heart attack. It's
Awesome.
6 weeks.
Okay. Okay. So after an urgent pacemaker installation, how long should you wait to get a cardiac MRI to rule out sarcoid?
Wow, everyone wants to see what my heart skills are today. So, number one, if you have a pacemaker in year 2024, most pacemakers should be MRI compatible. That's just the way it should be. But you know who knows more than me talking during this conference is your cardiologist. And you need to ask, is my pacemaker going to be friendly for doing MRIs? Now, this is where it really kicks in again, 6 weeks, because when you do an MRI, everyone, what's your hands going to do? They're not going to be like this. Most of the time, your hands are going to be up above your head or maybe like this. And what did I say? You can't put anything above your head. So when you have the rule of thumb, no MRI just based upon putting your hands above your head if you had a pacemaker or ICD, and triple, quadruple check that it's going to be MRI compatible. Excellent question.
Awesome. Awesome. Well, let me relieve you and maybe get into the pulmonary family with some questions.
Oh, now you're taking it easy on me. Now we're going about lungs. Okay, we can do this all the
time. So next person is curious about the criteria of the stages of pulmonary sarcoidosis and also the criteria for determining pharmaceutical treatment.
Oh, wow. So things have changed. What a surprise. You know, when I was a med student, I always like saying that, it was all about knowing the chest x-ray stages, right? And we all memorized the 4 big chest x-ray stages where you shoot a picture and you just have some hilar fullness. The hilum is kind of like this area in the center of the chest. It looks like you have 2 big potatoes on both sides. And most likely those are going to be lymph nodes. And that's the classic, hey, I have sarcoid in my thoracic cavity. I'm just going to watch it. As you progress on, you could have some hilar lymph nodes and you could have some markings in the lungs. We call those interstitial markings. Then all of a sudden, you know, the third stage could be, it looks like you're starting to develop some fibrosis, but you don't necessarily need to have this hilar fullness. Then the fourth stage is just, now we're talking about the word fibrosis. So, you know, I don't take things solely based upon those classic x-ray findings for one reason. Tell me if I'm wrong, audience. Everyone seems to get a CT scan lately. Everyone just wants a PET scan lately. So when you're getting a CT imaging, of course, it's more detailed and you'll see things that you definitely can't see solely based upon the chest x-ray. You know, I really truly feel that this is a discussion because the more you image people, the more you're saying, let's get a CT of this and CT of that, you find things you want, but then you're going to find things you really don't want. These, oops, I found this, and it really causes a lot of stress. But based upon a lot of people getting CT imaging of the chest, I would say that we tend to know a little bit more. We tend to have more rules where, hey, if you have a nodule, if you have some kind of plaque, of course, now that we found it, we're going to monitor it. And more than just imaging, it's going to be symptoms. And, you know, those symptoms could vary. A classic symptom could be, I'm short of breath. Sure. Is it from the sarcoid? But could it be chest pain? Could it be cough? There's always going to be atypical presentations. So once again, the answer is, do I feel your shortness of breath is truly from the sarcoid? It's not from someone who has a history of smoking and COPD, not from a history of asthma, which kind of mimics sarcoid quite commonly. And once I know it's from the sarcoid, I think that even though it makes sense, the worse the chest x-ray, the more likely to have, you know, and symptoms, the more likely I'll give you therapy. Things always vary. But I will say, now that we're talking about fibrosis, which would be historically, you know, the chest x-ray, you know, type 4, things that we see now on CT scan, there are anti-fibrotic medications. And I'll say that this is a great question to ask your sarcoid doctor, that there is a medication, the brand name, I don't promote it or anything like that, is called OFEV. And its claim to fame is that it was used for pulmonary idiopathic fibrosis, but they did studies to show that it can be used for a variety of what we call interstitial lung disease. And once sarcoid affects the lungs, the body of the lungs, it's kind of like an interstitial lung disease. And if you have fibrosis, this is a medication that actually slows down the progression of fibrosis. Now, granted, it has a boatload of side effects. Granted, it's not going to be cheap. But it's nice that you know that if you do suffer or have pulmonary fibrosis, there is a medication that slows down the deterioration in the lungs and got approval for sarcoid patients who have pulmonary fibrosis. So something to just at least talk about to see if maybe down the line or right now you may be a candidate for the medication.
Awesome. Awesome. There's a lot there.
There's a lot there. I couldn't believe how
Yeah.
much I yacked about that one, dude.
So does active or symptomatic pulmonary sarcoidosis get worse if left untreated by medication?
Ooh, you know what I love about these questions, Sean? I don't know if they're just like, quizzing me because they know the answer, because I feel like these are the stuff my med students ask me. But so the answer is that if you have sarcoid in the lungs, that once again, I always like being half as glass full, that most people don't go on to develop the fibrosis and end-stage lung disease and end up on the transplant list. Most people may never get a flare, and most people may go into the word remission. And even if you don't give steroids, even if you don't give disease-modifying anti-rheumatic drugs, some people do. And that's the good thing. So people tend to forget, how do most of us see our patients with sarcoid? It was, doing a physical, or for some other reason, they're getting images and they saw some kind of nodule or lymph node and they're like, you have cancer. And they went to panic. Or you have tuberculosis or this fungal infection. And everyone's in like, what are you talking about? But then after they did the workup and everything, they're like, no, it's sarcoid. So sarcoid's always something that just kind of pops up sometimes. Sometimes I have many patients who have cancer. Like I am thinking of one patient right now that was diagnosed with breast cancer. And during the eval, they found some granulomas. So, it's the reason why I'm telling this story is that sometimes it just it just pops up out of nowhere. So to answer your question specifically, even with no therapy, if we're just monitoring you, yes, it can go away, but you need to be monitored. The magical words are active surveillance. But hopefully, if we do treat you, and just remember, when we say treat, I'm not going to treat asymptomatic people in the lung. I can guarantee you I'll give you more symptoms from the steroids and these disease-modifying drugs versus just watching you, especially if you're asymptomatic. And sometimes the lymph nodes will decrease in size and it goes away. So I think it's always good to be positive.
So you mentioned remission.
Mm-hmm.
What defines remission in sarcoidosis?
Wait, is that your personal question, Sean? Because that's another tough one.
These folks were talking to each other.
Oh man. So remission, you could go to any textbook and they would not tell you the exact word of remission because every doctor uses it a little differently. And I will apologize to everyone listening that it's frustrating when people just say, oh, you're in remission. You're like, what does that mean? Because remission doesn't mean you don't have the sarcoid anymore. And the minute you have sarcoid, you will always have sarcoid. And that's not me being negative. I'm always a positive person. It just means that you're not having the active inflammation. You're not having active disease manifestations. It's kind of like just sleeping, just sleeping in your body. You know what I mean? So when we talk about, I have a patient and it never flares and it remits, it just means that it may regress in size sometimes, but even if the size of a lymph node or a lesion doesn't regress, if it's not causing any symptoms, that is when many people call it remission. And let me just say one more thing. You could still be on medications and call it remission. I have patients on methotrexate or Imuran, Cellcept, and they're in remission. And then the question now becomes, do we take off that medication? Because no one likes to be on lifelong meds. Then the biggest argument kicks in where, let's say your flare was in the eye, in the heart, in the brain, that I don't know, even if you're in remission, if I want to risk it flaring again, because of course, even if you're in remission, can you get a flare? Yes. And I think that's the hardest part. But if it's going to be like a lymph node in the lung or something on the skin, or I know that if there's a chance of it remitting, it's not going to be something life-threatening, and you're having side effects from a medication, then I'm going to be more aggressive. And I think as a rule of thumb for everyone listening today, no matter what drug you're on, a good thing you could do to be proactive is be on the lowest dose of that medication to keep you in remission if that's possible.
Sounds good. That was a
Mhm.
really good question. Sorry about that.
That was a
I was
good
wondering about that too.
question.
So
Yeah.
I like the way you answered that. That was great. So let's move to someone has been newly diagnosed with neurosarcoidosis, and they were curious about your experience with people that have been newly diagnosed with that, and then the prevalence of migraines with sarcoidosis.
Whew. All right. I don't remember the questions being this hard last year, Sean. I don't know if you're doing a giveaway on the other side to stump Dr. Raj or something, but I think, the hardest sarcoid to diagnose is going to be heart and neuro and eye. But what do they have in common, Sean, is that you can't make a tissue diagnosis there. So
Yeah.
people are always wondering, why do we get PET scans? And in olden days, gallium scans, and all these crazy scans? It's because we're trying to find easily accessible tissue to make a diagnosis. I mean, it's kind of convenient per se that sarcoid affects the lungs quite often because many pulmonologists are okay about doing bronchoscopies and all these crazy things when you do these bronchoscopies to get tissue. So the first thing is, how do we make the diagnosis? Especially if someone's going to throw me a curveball and say, they're only manifestations in the brain. They're only manifestations in the eye where it's hard to see these non-caseating granulomas. And let me just throw this out here. Let me go on my little filibuster, is that I hope everyone remembers, just because you find a non-caseating granuloma in your body, it doesn't mean sarcoid, because it's going to be the non-caseating granuloma plus the history and physical. And there are other crazy diseases out there that do present with non-caseating granulomas also. So I just wanted to say that. So neurosarcoid, if patient came in and did not carry the diagnosis, that's going to be a hard one. And of course, how do we go about doing it? It's going to be, think of a puzzle, me collecting a lot of pieces. I'm going to get serological testing. And even if you want to roll your eyes, I may say the word ACE level. One of the biggest things nowadays is getting an IL-2 level, whether it be in the CSF or in the serum itself. I'll get inflammatory markers. I may check your urine, see if you're dumping a lot of calcium in there. I'll get a lot of things to help me say that this puzzle is kind of looking like a sarcoid type patient. If it's going to be in the central nervous system, I want to know, are we worried about seizures? Are we worried about, a mass effect of some kind of lesion? So the answer is MRI. I'm going to have to get an MRI. And of course, because I'm ruling out many things, don't be surprised if you get a lumbar puncture and me checking many different things in there. So even with all these things that I do, it's still going to be under the category of high probability, moderate probability, high risk, because many things mimic sarcoid. And I think many people listening today will agree with this statement. Multiple sclerosis and sarcoid really do mimic each other. And I have many patients where they called it MS, or it used to be MS, or now it's MS, and what's going on here? So it's tough. And it's very, very hard to get tissue diagnosis in the brain. So once we talk about neurosarcoid, this is something I'm going to be very aggressive about. I'm going to be super best friends with a neurologist that hopefully is familiar with neurosarcoid, because I do need them to follow up with me and interpret MRIs of the brain, consider doing an EEG of the brain. And if we don't know for sure, I've had patients where we would say it might be MS, multiple sclerosis, or sarcoid. There are certain drugs that we could use that kind of treat both. And sometimes we have to do it that way because it's just hard. But I would just say that if it's neurosarcoid, it's always good. Or just in sarcoid in general, have your questions. What do you think, doctor? How do you know this is for sure? Are we going to have therapy? Is this going to be something, how can I expect? And of course, follow up for neurosarcoid and cardiac sarcoid and ophtho. You know what I mean? It's going to be in the beginning a little more stringent. So be prepared to have a lot of follow-up visits on those during that time.
Awesome. Awesome. Great, great answer. Next question is maybe centered around some tips on medication timing. So a lot of patients are on steroids, methotrexate, and gabapentin.
Oh,
I didn't pronounce
gabapentin,
that right.
gabapentin.
Yeah, that one.
Yeah.
So, the question is more centered around any tips on the medication timing. Do you think that's how it's proposed by the doctor, or is there different stages that the medication gets presented, I guess, or suggested rather?
No, that's a great question. So, I think that's the hardest part because if you see a sarcoid doctor, I mean, I'm sure him or her are going to be the best sarcoid doctor in the whole world. But remember that, when we prescribe medications like gabapentin, and maybe people don't know it by gabapentin, but who's heard of the word Neurontin? Yeah, that's kind of like everyone, right? Who's heard of the word Lyrica? Yeah, that's like everyone, right? So gabapentin is kind of like the generic name of the medication. And when do I use things like a gabapentin, like a Neurontin, is when you have neuropathy, when you have some chronic pain issues. And of course, one of those indications for being on a Lyrica Neurontin type drug is, have you heard this word before? Fibromyalgia. And I
Mhm.
got to tell you, I have many patients who have sarcoid and fibromyalgia, and that stinks because the question always becomes, is it my sarcoid flaring or is it my fibro flaring? And it's so hard to distinguish. But people don't realize that gabapentin makes you a little sleepy, for some, not at all, because they're on such high doses, and you could really crank that bad boy up. I mean, you could be on 300 milligrams 3 times a day. It can get really high up there. So usually, tell me if you heard this before. If you're older, we start low and we go slow. But I would usually give it at night, you know what I mean? Just so they could just fall asleep. And during the day, they won't be falling down or anything like that, and see how they tolerate it. And I'll slowly titrate up the medication. So I would say in someone gabapentin naive, I would start giving it at night at a lower dose and see if they're getting success from the medication, less side effects, and go up. Another big one is going to be steroids, that yes, everyone has been on steroids. And for me, I think that steroids need to be given in the morning. Why? Is because of insomnia. And I can't even begin to tell you how important sleep is when we talk about inflammation, we talk about your weight, we talk about your heart health. And of course, if you're taking steroids, especially higher doses of steroids, before you go to bed, and that's just going to keep you up. That's just going to give you some serious insomnia. Not to mention, I'm sure everyone has been through this. When they restart a taper of steroids, they give you like 40 to 60 milligrams of bread. Oh my God, you could get psychotic from it. It's just like, whoa, what happened? So I definitely would say steroids. I definitely would take it during the day. That's going to be very important. And one of the things I also want to mention about timing, this is not about the hour you take it, but more of what day to take it. So for those who don't know, my wife is a rheumatologist, and that's one of the big reasons why I do sarcoid, because I feel the more I hug my wife, the more familiar I am with rheumatology, and her knowledge will come to me. So I think many people are taking methotrexate, and it's a once weekly drug, which is, I think, really cool. You know what I mean? It's good for compliance. So my wife always tells her patients, take it on Monday because it's like methotrexate Monday and you'll never forget. And I'm like, oh, I like that. So everyone, if you wouldn't know when to take it, take your methotrexate on Monday. And of course, I don't want to quiz anyone, but almost every day, what vitamin, what supplement do you need to take if you're taking methotrexate? Did someone type it in?
Yeah.
All right, folic acid. You need to take folic acid. Now, someone will be like, what? My doctor prescribed an L word. And so there's something else called leucovorin. So leucovorin is kind of a pricey, I think it's folinic acid, which is kind of a brother of folic acid. And you could take that weekly. So if you really just don't like taking anything every day, you could take leucovorin. But folic acid is important because that's how methotrexate works. It inhibits folic acid. And if you don't take folic acid, you can get a lot of those side effects.
Okay, I'm going to stay on that methotrexate question. So I won't be able to pronounce this accurately, but the question is CellCept just as effective as methotrexate and
Azathioprine.
that one in
Yeah.
helping avoid a resistance to Rheumatoid infusions?
Oh my Lord. All right. So when we talk about, you know, the big topic is Demars, and you'll hear doctor people say the word Demar, disease modifying anti-rheumatic drugs. So if you have any flare of sarcoid, pretty much guaranteed they're going to give you some steroids. If it's going to be oral, it's going to probably be the P word, prednisone. And like we were kind of talking about, some people just remit after a course of prednisone. Some people get stuck on the prednisone, or people are still having continuous flares, relapsing and remitting, relapsing and remitting. So then we think about using a non-biologic DMARD. And that's the key thing I want to talk about this, is that DMARDs are here. There are biologics on this side and non-biologics. So we usually use non-biologics first because, diet biologics really suppress that immune system, making you more susceptible really to infections. So in my opinion, the three most common non-biologic DMARDs I use are methotrexate, mycophenolate, which everyone uses the brand name Cellcept, or azathioprine. And the answer to your question is, it really depends on who you are. When I use these medications, it's going to be what your doctor feels comfortable using. Some doctors just weren't trained using azathioprine, so they don't use it as often. Some people use a lot of methotrexate, so they use it more often. Methotrexate, in my opinion, probably has the most clinical data in regards to for sarcoid, but surprisingly, it's not FDA approved for sarcoid. We just steal all these drugs away from the rheumatologist and we use them ourselves because we know the immune system plays a big role in sarcoid. Though sarcoid is not big old NOT, an autoimmune disease, the inflammation involved in the granuloma formation involves T cells and B cells and all the things that are being inhibited when we talk about other rheumatological diseases. So my answer to you is that whatever you feel comfortable with. And of course, certain drugs are very liver metabolized, so you don't have to raise your hand. If you're a big fan of a couple beers and some wine, maybe methotrexate is not your drug. For Cellcept, which is mycophenolate, I start off at 500 milligrams once daily, and I titrate up to 3 grams. If you could tolerate the nausea and some of the GI discomfort, that could be a good drug for you. And azathioprine, you definitely want to make sure that you're following up on CBCs. It can be a little liver toxic. So it really depends. It's individualized. But all those three are my core drugs that I use for my first non-biologic DMARD.
Gotcha. Wow. Yep. That was a doozy.
That was a doozy. I mean, I tell you, I learned more doing this stuff with you guys than the medical students and residents. They got me for all these conferences. They never ask these great questions.
They're doing really well tonight. Yeah. An easy one. Does sarcoid cause a low white blood count?
Oh, nice. So when we talk about in general, patients who have sarcoid, regardless of where it's involving, are often associated with lymphopenia. But, of course, when I hear a question about a cell count being low, being anemic, low platelets, of course it's implying is a sarcoid in my bone marrow? And the answer is sarcoid can pretty much go anywhere. And I have seen sarcoid in the bone marrow. And how are you going to prove it? Well, this is going to suck. You need a bone marrow biopsy. I don't know who's had one already, but some people may have to get that if they feel it's going to change their management. So one of my patients who has sarcoid in the bone marrow was really worried that, hey, my lymphocyte count is low, and what am I going to do? Should you blast me with steroids, put other things? And, a lot of these DMARDs, whether it's biologic or non-biologic, can be a little toxic to the bone marrow. So the answer to the question is, if you're lymphopenic, I really do get concerned when you're showing clinical manifestations of repeated infections. So if you're telling me, I'm getting sick every other day, then I am concerned that, hey, sarcoid could be actively in your bone marrow and having active inflammation. And in those cases, I do have to work closely with a hematologist because, once again, sarcoid, what I do, I'm kind of like the quarterback, but you never want to fake it. I don't magically have a hematology degree or a neurological degree. So you really want to be a team player, be amongst people, and we'll make a decision about starting you on immunosuppression for the bone marrow. And the trick is picking drugs that don't also suppress the bone marrow. So to answer your question, definitely associated with some lymphopenia, but in itself, that question itself doesn't mean that you're going to have a worse mortality, worse survival, or have repeated infections. But if you are getting repeated infections, we do want to be aggressive about therapy.
Awesome. Awesome. You know, we just got a question on blood clots.
Oh,
And
okay.
so the question is this patient was recently told that sarcoidosis can elevate your chances of forming blood clots. I guess two questions. Is this
Yeah.
true first? And then the second question is, have there been associations with inflammatory and/or autoimmune conditions and blood clots?
Oh, great. So for sarcoid itself, the answer is no, not yet as a risk factor for blood clots. And, I think that indirectly, if you have someone who has sarcoid and they're stuck on prednisone and they're going to be, unfortunately, overweight or obese and is not as mobile, and as a woman and is postmenopausal and taking estrogen at the same time, or it's a man or woman and smokes at the same time, sure, these things could all be additive. But I don't want to scare anyone, because most people with sarcoid are what? Asymptomatic. Most people with sarcoid just has that fullness in that area in the chest called the hilum, and they live happily ever after. So to say that sarcoid will put them at a risk for inflammation, a risk for blood clotting, would scare a lot of people. So as of right now, the answer is no. But I like the follow-up question, because if you were to say inflammatory diseases such as rheumatoid arthritis, such as lupus, yes, anytime you have inflammation in a vessel, of course, that's going to put you at a higher risk for clotting, because there's just inflammation where the blood is going to be flowing through. So not to say that certain individuals with sarcoid can't be at that higher risk, but to say it as a generalized statement wouldn't be as strong as someone like a lupus who's actively flaring, or rheumatoid arthritis. So I think of those individuals to be at a slightly higher risk, especially if you're not controlling their disease state. But for most people with sarcoid, no, I would say I don't think about blood clots for them.
Awesome. Thank you for that. And this is a question that I've never heard of,
Yeah.
and it's relative to sarcoid in the lungs.
Oh, okay.
So one patient would like for you to explain what ground glass is.
Oh man, I think I have a budding radiologist in the audience. So that's who uses the word ground glass is the radiologist.
Oh,
So we use that word when you get a CT scan of your chest. And next time, Sean, maybe I'll bring some CT images so I could point some out for you guys. That'd be
yeah,
kind of
that'd be
cool.
great.
Maybe radiology with Dr. Raj. um, so when you look at the CT, ground glass is literally what it is. Imagine some glass and you just kind of smush it down and you just kind of sprinkle it in the lungs. It's a very non-specific finding. So if my resident or fellow says, "Hey, Dr. Raj, the CT shows ground glass." Ground glass could be infection, it could be fluid overload, it could be blood, it could be pus. So many different things could represent ground glass. It's just a radiographic description. So in the context of sarcoid, if someone who's having a sarcoid flare gets a CT and there's a lot of areas of ground glass, then it may imply that could be the sarcoid kind of just causing inflammation in the lung. But how would I know for sure it's not something else? Now that's the hard part, because if you're having a sarcoid flare, then I'm going to give you steroids, immunosuppressants. But once if you have a little pneumonia, once if you had COVID, once if you had RSV, once if you had influenza, once if it's something else. So that's why many times the pulmonologist may tell me if the people listening, if you heard this, you know what, we may have to do a bronchoscopy. And you're like, really? Another one? I know they're not fun, but it's so hard to guess. You know what I mean? And sometimes maybe if my patient, I know them so well, this is exactly how they flare. Sure, we could give some steroids and see what happens. But if it's something where it's like they just came back from a different country, they were exposed to their grandkids, or something just doesn't feel right, yeah, I may have to put them through a, oh, I'm sorry, bronchoscopy just to make sure we're not missing some kind of infection or something else before I immunosuppress you. So ground glass, simply put it, is a radiographic description of a CT image of the lungs.
Gotcha. Okay, I'm gonna bounce around a little bit. That was
Do a little bouncing around. Okay.
yeah. I mean, so let's talk about vitamins and supplements.
Sure.
Is there any that you recommend and any that you would want the audience to avoid?
Excellent question. So let me just say this as a generalized rule. There is zero data to show that taking super therapeutic levels of any type of supplement or vitamin is going to be of any benefit. Now, if you're low in something, that's a different story. You know what I mean? So definitely if you're deficient in a vitamin D, you're deficient in magnesium. Of course, taking a supplement because you're deficient makes perfect sense. And the question is, why are you deficient? Are you having is it because of your dietary choices? Are you having a malabsorption? Is there pancreatic issues? So you always have to address the question why. But, supplements, vitamins, is such a hot topic in that money-making part of medicine. And I can't tell you how many different articles always get sent to me that says, hey, we tried taking extra testosterone or tried taking some extra creatine, take some more magnesium. So that's such a hot topic. And I would say this, if you're taking a supplement, the cheapest, easiest way to take a supplement is to just modify your diet a little bit. You know what I mean? So I know that I truly do believe if you're going to eat well, it's nice to have some antioxidants in there. And for me, antioxidants means blueberries. It means some pomegranate. You know what I mean? I love magnesium. You could eat some almonds if you want to, drink some almond milk, So I think modifying green leafy vegetables is a good thing. So I think always being involved with a dietitian, nutritionist is very important because there are many people who are listening today who would be like, I don't want to go on these drugs. I just want to do, emphasize what I call the pillars of good health, which is diet, exercise, sleep, and not being stressed. So yes, I think that I wouldn't recommend any specific supplement. If you do need one, ask your question why. And if you are taking one, you're not a bad person. Everyone's taking supplements, but just, bring it up with your doctor and get his or her opinion about you taking the supplement.
Yes. Excellent. Try a little bit of everything, right? So back to some medications. One patient wants to know, when on prednisone and methotrexate, are there any immunizations that we should have because of a lowered immune system, is the first question. Second question, if yes, can they be received while currently taking meds?
Nice question. So I think this is why having a great primary care doctor is important, and don't put all your marbles in the sarcoid doctor taking care of everything, because how familiar is a doctor with age-appropriate vaccinations? So being a pulmonologist, I'm going to kind of lump sarcoid into my pulmonary, world, that there are guidelines you're going to follow regardless. You know what I mean? And I would say that, of course, I always worry about strep pneumo. And, if you have pre-existing lung disease, you can take the strep pneumo earlier. The big one right now for strep pneumo is the 20-valent. That's the be-all, end-all. So you could read about that. Definitely, I love taking the annual influenza. I think that if you're immunocompromised, older in age, yes, I think COVID is necessary. You could roll your eyes. I apologize. I think RSV is necessary now that's FDA approved for people who are going to be 16 over and you're immunocompromised. And, I'm going to throw a curveball in there. So, Sean, I just literally was on the news a couple of days ago about a topic called the 100-day cough. Have you heard about that?
No, I haven't. Please tell me a little bit more about that.
So,
Interesting.
And I'm so honest. So they called me up it's always last minute, right? Hey Raj, can you go on the talk about the 100-day cough? And of course, you don't want to say no to these opportunities. So I'm like, yeah, dude, I'm in. Then as soon as I got off the phone, I'm like, what the hell is the 100-day cough? so,
Exactly.
so
I'll
I
figure it
looked it
out.
up. So have you heard of the bacteria is called Bordetella pertussis?
Okay.
That's the name of the bacteria, but we call that the whooping cough. Does that sound familiar?
Yes.
So the whooping cough is actually more common in pediatrics than in adults, and it initially presents like a viral infection, and you might miss it, but as it progresses, you get these inspiratory whoops like it's really scary, and in kids they almost could not breathe at all. And why am I bringing this up is because can adults get it? The answer is yes. If you love snuggling with grandkids, you're immunocompromised, like my sarcoid patients, So I would talk to your doctor about getting the booster for the whooping cough. It's called the pertussis vaccine, and it's usually combined with the tetanus vaccine. So,
Okay.
you're going to get the tetanus, like I think it's every 5 or 10 years. And then you can just say that, hey, I want the Tdap, where you add that P, which is pertussis with that. So I think being up to date with vaccinations is very important. And to answer whoever question it is, I would not take a live vaccine. You know what I mean? So influenza, the virus, there's a live vaccine you can take with a nasal spray. That sounds like a bad idea. Make sure you take inactivated vaccines. Once again, shingles. Everyone who's listening today, who's had the shingles? Everyone.
Yeah.
If you're immunocompromised, you're on certain medications, it's definitely going to get back. So nowadays we recommend a newer shingles vaccine called Shingrix versus the one in the olden days called Zostavax, which is a live vaccine. Why do I want to give a live vaccine to anyone? So I think it's important, if you don't remember these things, that ask your doctor, is this a live vaccine or not a live vaccine? And I think that, and ask, hey, from a respiratory standpoint, what should I be up to date with? And I think it's very important. It's a very good question.
Sure. Yep. Awesome. I'm going to throw you a curveball.
Yeah, totally.
For the next question. So we have someone on the line that is joining us from Australia, and she is actually north of Sydney.
Wow.
And so I want to make sure I get to her question. I think it's pretty cool. So again, back to our earlier question and discussion. Maybe this spurred on her question. But she had an ICD inserted a year ago, had a pacemaker, was in remission for 18 months with no meds. Since the ICD, been on prednisone and methotrexate, still tapering off of prednisone. So her lung specialist said last week that her PET scan showed no lung involvement last year, but there was an inflammation in her heart. His thoughts were that the heart inflammation could have been due to scarring rather than a flare-up of cardiac sarcoid. And this has just thrown her thinking around. So she's interested in finding out maybe what your thoughts are, or if you had any observations.
Sure, great question. So if you have a scar in the heart, well, one person your cardiologist could refer to is an EP specialist. I believe that stands for electrophysiologist. It's a subspecialty of cardiology. And if you have an area of scarring, that usually is a source of many different arrhythmias. So one thing an EP specialist can do is go to that scar area and say, hey, is it a source of arrhythmias, and may ablate it. So I think getting an EP specialist is going to be very important. And a lot of why they did things really comes down to, let's say sarcoid is not even part of the question. Let's say someone has heart disease, you know what I mean? In our country, high blood pressure and coronary artery disease are two most common causes of heart disease. If your ejection fraction in the heart is less than 35%, that in itself is an indication to put in an ICD. So I want people to realize that, whether your sarcoid is flaring or not flaring, once the EF is less than 35%, that's an indication to place it. People also forget to mention that even if you have sarcoid-induced heart disease, Now you have heart disease, you have heart failure. You need to be on the appropriate treatment for heart failure. In between that, sure, if you flare, we could talk about immunosuppression, but you also need to make sure that you're on what's called GDMT, goal-directed medical therapy. And that's for everyone who has heart disease, that you are now in that big bucket of heart disease and need to be on those therapies. So the answer is I've had patients who had scarring in the heart, and they've seen that whether it be on a cardiac PET scan or a cardiac MRI. I think it's reasonable to say, is there a chance that, especially if your ICD is flaring off or you're having arrhythmias, to see if EP could be using to evaluate it. But yeah, I don't think we could just, those would be the first steps that I would take, and you're doing the right thing, which is trying to get in the lowest dose of the medication and go from there. That's really a really tough case. And, I'm glad she asked that one.
I thought it was too. And
Yeah.
I wanted, like in anything, she's trying to figure it out and reaching out. And,
Yep.
I think it's 9 a.m. or something over there or something like
Yeah.
that. So it's just like amazing that, we're making connections out in Australia. So I thought it was pretty awesome.
No, and that's a testament to the Life and Breath Foundation. I remember when I did this many, many years ago with you, Sean, we didn't get this many people. No one came in from like Australia. So I'm really proud of you and your foundation. It's just amazing.
Well, thank you. It really, our objective was we understand that there's many people around the world in different parts of the country, domestically, that don't have the information, to help them with the navigation. And sometimes they ask really good questions and, they can't get the answers. And so frustration sets in, and then they feel like they're by themselves. So the premise behind this is that if we can help, if we can bridge the gap and get you what you need, no matter where you live, that's what we want to do. And just get them to come back. So you being able to help us with this is a big, big, big joy and everything. And so we appreciate you taking the time to do that.
Sure. Yeah. Oh, yeah. I see, Abigail. Are you waving to me or give me the 5-minute count? Oh, the 4 or 5 minute. We could do a one more or so. We could squeeze one in there, Sean, if there's no more.
This is something I didn't know. I mean, it's one question is, does sarcoidosis raise your ATCH levels?
Oh,
and I'm not sure what that sounds for.
No, you know what? So ACTH is a hormone secreted by the anterior pituitary. I don't know why someone's talking about this, and I kind of think I know where they're coming from. So what happens is that when you want to secrete cortisol from your adrenal gland, our bodies naturally make a prednisone type hormone called cortisol. You get signals that secrete ACTH. So if you have sarcoid, I don't see why sarcoid in itself should secrete ACTH, but there's always buts. There is a medication category out there that we use to treat people with sarcoid. And in fact, this medication category is FDA approved for sarcoid, go figure. And there are 2 competitors out there. One goes by the brand name Acthar. I don't know if anyone listening has ever heard of Acthar before. And then they have a competitor out there that I think their brand name is called Cotropin. Now, I hope I didn't mess that up. But what do these drugs do is that they kind of mimic, per se, ACTH. So when you give the medication, it will activate cortisol release from the adrenal gland. But to be honest, for both medications, they did studies to show, does it do something else besides secrete cortisol from the adrenal gland? And the answer is yes. That they have been shown in studies that it actually will modulate your immune system. So you do get some steroid benefit, but you don't get the steroid side effects. And it works. And this new category called ACTH-like drugs are used for sarcoid patients. So great question out of nowhere. I don't know if that's where he was going with it, but I hope everyone benefited from that knowledge.
Yeah. No, Dr. Raj, wonderful. We have 2 minutes left, and I want to maybe open it up to you to be able to maybe give us some closing thoughts, with some of the questions that were, asked and answered, and what you're experiencing in your practice and the connections that you've made. Is there anything that you could share with everyone that's on the line and those individuals that are benefiting from the information that you've been able to share?
Oh, well, I wanted to say this is that, right now I'm at Huntington Hospital. It's in Pasadena, and we're, affiliated with Cedars-Sinai. And I'm starting my own cute little sarcoid center here. And I just wanted to say that. And one thing I realized is that, it's access to care. And I think that I noticed it in the sense that when you're part of, the big university systems, that things are at my fingertips to do certain things, but my heart really goes out now that I'm trying to do things on my own with what things I have available to me. It's hard for patients, and it's hard to like get referrals, and it's hard to get your tests that you order. So I really, it's a new stage, and trying to put myself in the patient's shoes so I could really even understand more now how frustrating it is to carry the diagnosis of sarcoid when you have no one around you. And by no means am I stuck in the desert. I do have wonderful people around me, but it's new to me. And I just wanted to say happy April to everyone. It's Sarcoidosis Awareness Month, and I really enjoy being here. And hopefully, I'll be back soon to answer more questions. I really want to compliment. Those were some of the best questions I've ever got. I mean it, not just to stroke everyone's ego. These are better than my resident fellows questions. So I just want to say. Congratulations and good luck for everyone. Stay strong, and hopefully I'll see everyone soon.
Dr. Raj, thank you very much. We appreciate your time, and you've been very beneficial and helpful. We hope to have you back again very soon.
Thank you, Sean. You're the best. And thank you, Abigail. You're great at posting, okay?
Have a great evening.
All right. Bye, everyone.
Take care.
Okay.